right.
Hi, thank you for attending today. I'm going to be speaking on Does Social Prescribing Improve Pediatric Health Equity? This is a portion of a study out of my mixed methods dissertation entitled Social Prescribing to Promote Child Health, Experiences, Outcomes, and Equity. I'm going to just level set by defining a few terms as I'm using them. Interventions addressing social needs in the healthcare setting are generically termed social care. A common subset of social care is social prescribing, or providing resources and referrals in response to a social needs screening. Often, a stated purpose of social prescribing interventions is to improve health equity. In this chart, you'll see some outcomes of social prescribing interventions. So the effectiveness of social prescribing has largely centered on process measures. The majority of programs report successfully identifying unmet needs and providing resources. However, patients' ability to access resources is often mixed, with some programs reporting higher success than others. At the time we developed sort of this study, according to the PCORI Social Needs Evidence Map, about 50 studies had evaluated social care interventions in children, and only 4 were rated high to medium in quality that specifically addressed social prescribing. In addition to sort of the PCORI evidence map, I included an additional 2 related randomized controlled trials through my own lit review. And notably, none of the studies had used stratification to evaluate the impact of health equity. For this project, I used Children's Minnesota Community Connect as a representative social prescribing program. In Community Connect, families experiencing an unmet need like food insecurity are identified at a standard well child screening or during a conversation with their provider in a non-well child appointment. They are connected with a resource navigator in person or over the phone. The resource navigator provides a custom list of resources and/or referrals, and families and navigators remain in contact until a family meets their need or no longer wishes to participate. I would describe this program as a higher touch program than a lot that have been presented so far. In 2024, SIREN published an updated logic model that proposed multiple mechanisms by which social care impacts health. In qualitative interviews in this work, we found that caregivers that participated in Community Connect discussed positive emotional support provided by resource navigators. And we felt that may impact their feelings about their clinic and subsequent well child attendance. And this presented the basis for the quantitative study being presented. There are 3 aims to the study. The first was to build an inferential model to test the effect of Community Connect on well child attendance, influenza vaccination, and acute asthma exacerbation. A secondary aim was to identify patient characteristics associated with participation in Community Connect. And a third aim was to test whether Community Connect produces health equity among key equity targets, including race, ethnicity, primary language, and socioeconomic status. The majority of my results will be presented from aim 3, but I will present a little bit from aims 1 and 2 to kind of set the stage. Data for this study was obtained from the Integrated Health Partnership, which is an accountable care organization of model for Medicaid in Minnesota. IHP patients are attributed to a health system based on a plurality of their prior primary care, and health systems are at financial risk for meeting cost and quality of care metrics for attributed patients. Health systems are also receive a population-based payment for care coordination and are required to design a population health intervention to address health equity. I bolded that last part because Community Connect was actually developed in part to meet this requirement. And secondary data sources for this study include the Community Connect REDCap database and supplemental information from the electronic health record. This is a retrospective cohort study leveraging general structural equation model path analysis. We included all patients attributed to Children's Minnesota for at least 6 months in 2018. We excluded patients who didn't have the opportunity to participate in Community Connect because it wasn't employed in their clinics, patients that didn't have an index visit in 2018, and were not continuously enrolled in the IHP for at least 12 months following that index visit. All outcomes were identified using aggregated claims files up to 13 months after the patient's 2018 visit. The primary outcome was a subsequent well child visit within 13 months, and secondary outcomes included influenza vaccination and asthma exacerbation. Influenza vaccination and asthma exacerbation were selected because they have been associated both with well child attendance and adverse social determinants of health. In addition, one is a preventative care measure, and the other is a chronic disease outcome representing the important prevention and management aims of primary care. Community Connect participation was identified using the Community Connect REDCap database, and participation was attributed to all children in the household. And for families that participated multiple times, we used the first date of participation in 2018. These are the additional covariates included in the model. Just going to highlight the ones that we used for stratifiers. So race, ethnicity, and primary language were self-reported to IHP. In cases where it was missing, we backfilled that with the EHR data when possible. And we also used houses to measure socioeconomic status. Houses is an individual level measure of socioeconomic status that uses housing characteristics, including a square footage, building value, and number of bedrooms and bathrooms obtained from real property data. And this is a validated measure that's kind of managed through Mayo Clinic. We had a total of 6,166 patients that met inclusion criteria, and roughly 10% of those patients participated in Community Connect. In our unadjusted analysis, we noted that Community Connect participants attended a subsequent well child visit at a rate of 62%, and non-participants at a rate of 53.2%. We also noticed that the months to that mean well child visit were slightly lower for Community Connect participants, likely reflecting the younger age groups that participate. So the first step we did was to take all of that data and create an inferential model. This is a general structural equation path model. For those of you that are familiar, it's very similar to a general linear model, with the exception that you can estimate multiple outcomes, as well as relationships between outcomes. These models are estimated using maximum likelihood, and the coefficients are interpreted similar to GLM coefficients. To test the hypothesis model, I employed Stata's general structural equation command for binomial outcomes, using a logit link and robust clustered standard errors to account for correlation within households. In an a priori test, we compared the fit statistics for emitting pathways B, C, and D in a stepwise fashion. We had strong evidence to admit pathways B and C, so thus kind of telling us that Community Connect did not have a direct effect on asthma or influenza vaccination. We also had weak evidence for retaining pathway D, and in an effort to prioritize parsimony, we decided to omit that from our model as well. So using marginal analysis, we reported the predicted rate difference of subsequent well child visit, influenza vaccination, and asthma exacerbation by Community Connect participant and well child visit respectively, standardized to the distribution of covariates in the sample. The effect of Community Connect was mediated through well child visit on influenza vaccination, and that is measured by path AE, or the blue dashes, and asthma exacerbation measured by path AF, or the purple dashes. Only the relationship between well child visit and influenza vaccination was statistically significant in this model, which would be interpreted as patients that attended a subsequent well child visit were 12.8 percentage points, had 12.8 percentage points higher influenza vaccination rate than patients that did not attend a well child visit. Notably, if you recall earlier, the unadjusted analysis, Community Connect participation resulted in about a 9 percentage point increase in well child visit in the unadjusted analysis. And here, once we adjust for potential confounders, it was only 2.9 percentage points and no longer statistically significant. As part of this process, we also wanted to identify characteristics associated with Community Connect participation. So here are the results of that sort of adjusted odds ratios. We found that sociodemographic characteristics that are key targets for equity interventions were significantly associated with Community Connect participation, particularly race, ethnicity, primary language, and socioeconomic status. Given the health equity intent of social prescribing, and that our findings suggest different rates of participation in Community Connect by key characteristics, we went on to explore whether the effect of Community Connect on health outcomes was equivalent across race, language, and socioeconomic status. Before I kind of get into the results from AIM-3, I wanted to clarify my definition of health equity. So health equity is the achievement of the highest level of health for all people, such that social circumstances do not affect health outcomes. Evaluation of health equity allows us to understand what works for whom and assess whether health inequities have changed. And programs that produce equity must have equal impact among those with equal needs, or horizontal equity, and greater impact for those with greater needs, or vertical equity. In the next slides, I'm going to graphically represent these two concepts. So assuming that the y-axis is a health outcome where the higher rates is better health, this is an example of horizontal equity. The intervention has equivalent impact on both groups that had equal needs. This is an example of horizontal inequity. Despite improving health, the intervention had a larger impact on one group, resulting in a new disparity. This is an example of vertical equity in which an intervention has a larger impact on group 2, resulting in a decrease in an existing health disparity. And this would be an example of vertical inequity. Despite improving health for both groups, the intervention has a larger impact on group 1, widening an existing health disparity. So the predicted rates presented in the following slides were obtained from 3 stratified versions of this model, one for race ethnicity, one for primary language, and one for socioeconomic status. The stratified models are estimated simultaneously using maximum likelihood. Thus, you can compare parameters between and within subgroups. Metric and scalar invariance was assessed for each model. Due to the collinearity of race, ethnicity, and language, they were not included in each other's stratified models, and we also found metric invariance in socioeconomic status model, so coefficients were constrained to be the same and intercepts were allowed to vary. Similar to the population model before, we are using marginal analysis. We reported predicted rates, and each predicted rate is displayed as a dot on the graph. We found mixed impacts of Community Connect on well-child attendance when stratified by key patient characteristics. Community Connect had a non-significant impact on well-child attendance by racial ethnic subgroup. In an example of vertical inequity, English-speaking families represented by the dark blue line had a statistically significant 3.2 percentage point increase in well-child attendance, thus increasing the disparity in well-child attendance between English, Spanish, and Somali-speaking families. And there was no difference in well-child attendance by Community Connect participation when stratified by socioeconomic status quartile. We noted modest impacts of Community Connect on influenza vaccination mediated by well-child attendance in the stratified models. Community Connect had a modest non-significant impact in influenza vaccination by race, a 1 percentage point increase among Black African American patients, and a 2 percentage point increase among Hispanic Latino patients. There is some evidence of vertical equity as the disparity in influenza vaccination between the English-speaking and Spanish-speaking subgroups decreased from 3.8 percentage points among the non-Community Connect participants to 1.2 percentage points among Community Connect participants. Conversely, the Somali language speakers did not see changes in vertical equity. When stratified by socioeconomic status quartile, Community Connect appears to increase influenza vaccination by approximately 2 percentage points. And overall, we saw no effect of Community Connect on asthma exacerbation. Consistent with previous literature, we observed higher predicted rates of asthma exacerbation among Black African American patients, Somali and English-speaking patients, and the lowest SCS quartile in our group. In summary, in our inferential model, we noted the direct effect of Community Connect on health outcomes worsened model fit. So this sort of does not support that we were resolving needs in such a way that they were improving health. In our population model, we noted the effect of Community Connect on well-child attendance was no longer significant after adjusting for potential confounders. However, we also did note significant sociodemographic differences in Community Connect uptake. In our stratified model, we noticed modest effects of Community Connect on well-child attendance and influenza vaccination when the model was stratified by language and socioeconomic status. And we observed only one instance of Community Connect improving vertical equity. Despite Community Connect appealing to groups that experience greater health inequity, we did not observe substantial improvements in health outcomes as a result of Community Connect participation. One explanation for this discrepancy is that the majority of social prescribing is informational and requires families to work with external community partners. In our qualitative work, many caregivers indicated that the benefit of Community Connect is knowledge, and that the administrative burden of accessing resources was a substantial barrier in meeting their needs. When considering health equity, we must be especially aware that these burdens may be even greater for historically and currently marginalized communities. I would like to thank my dissertation committee, my advisor, Dr. Rachel Hardiman, and Dr. Timothy Beebe and Nathan Shippey, as well as Dr. Nathan Chomlo. I also want to thank Children's Minnesota research team, our internal research grant program that funded the qualitative portion of this work, and my co-authors and co-workers, Dr. Mike Finch and Martin Koza. I also want to really thank the Collective for Community Health at Children's and the Community Connect staff, who both allowed me to evaluate their program, use their data, and also are really receptive to what 2.0 looks like. Thank you all.